Good afternoon, everybody. My name is Tomas Athey, and I'm part of Design Team number 12, and we're here to talk to you about our contraceptive implant training tool to be used in developing nations. All right, to give you guys a quick summary of this form of contraception, it comes in the form of a rod about the size and shape of a matchstick, and it is inserted directly under the skin and can last up to 3 to 5 years. 3 different companies make a contraception of this form, and their main differences are whether they incorporate 1 or 2 rods. The picture up there is a picture of a properly inserted 2-rod model. This form of contraception is growing in popularity in developing nations due to its efficacy, low maintenance nature, and low cost. Because of the large clinical impact contraceptive implants can have, scaling them up has been a focus of the Family Planning 2020 initiative, which is a global partnership between the Gates Foundation, USAID, and similar organizations. This partnership has helped reduce the price of contraceptive implants, and the price will again cut in half over the next 6 years. The demand for this type of contraception is over 200 million women worldwide. And if these implants are effectively distributed and healthcare workers are properly trained, then about 280,000 infant deaths and 30,000 maternal deaths will be prevented every year, and over $250 million will be saved in global health costs in developing nations. So use of this form of contraception involves 2 procedures, insertion and removal. Insertion is shown on the right, and this is a fairly straightforward procedure. Usually does not last very long. Again, the goal here is to insert the rod directly beneath the skin and not into the fat layer, because if it is inserted into the fat layer, the contraceptive will be ineffective and it will be difficult to remove. Removal is shown on the left, and this is a little bit more complex of a procedure, especially if it was inserted improperly or there was any weight gain during its use. After observing a number of procedures, we noted several problems in the current training tools. Current training tools do not simulate intricacies such as proper depth of insertion and scar tissue formation. Also, none of the current training tools trained for removal, and they did not emphasize the human factors of these procedures. If we can make a better training tool, then we can lower the complication rate of insertion and removal, which affects millions of women annually. This leads us to our needs statement. In developing nations, there is a need for a more affordable and biofidelic subdermal in-arm contraceptive implant training tool that effectively trains lower-level medical providers in the insertion and removal of contraceptive implants. Here we have a table of goals and constraints that we established in the beginning of the year based on end-user feedback, downfalls of the standards of care, and weather conditions in the areas in which our product would be used. We have planned tests to verify each of them. So here are the 2 current standards of care, the Earler-Zimmer model and the Rita arm. And here is a table comparing the features of our product on the right and the 2 current standards of care. Most notably, ours is the only training tool that trains for removal, simulates scar tissue, and ours is the only product that is wearable, a feature that Victor will now elaborate on.
Hello, everyone. I'm Victor Dadfar. And all right. So our design consists of 2 models, a standalone model and a wearable model. The standalone model has a PVC base, 3 layers of silicone, 1 of muscle, 3 of fat, and 1 of skin. The reason we included 3 fat layers was to increase the modularity of our device to simulate weight gain and loss over the course of wearing a contraceptive. Furthermore, the skin layer includes double netting to make it more realistic. Pictured here is our wearable model. The idea for the wearable model stemmed from the current protocol for training, which had students break up into groups of 3, 1 student acting as a midwife, 1 as a patient, and 1 observing. By having the patient student wear the wearable model and the midwife student practicing on that model, we added a human factors element to the testing that would simulate human emotions not present in the other models currently on the market. In addition to the layers of silicone included in the standalone model, this wearable model has an armband that protects the user from the trocar. And pictured here, we have the model with a darker skin color. Another novel feature of our design is the use of these silicone fat capsules, which include a placebo implant about the same dimensions as the real implant and cotton caps. The cotton is there to simulate the scar tissue that generally forms around the implants during the 3 to 5 years in the arm and makes it more difficult to remove. The pods can be inserted at various steps in the arm to make it more difficult to remove. Pictured here is a use of our model in a clinical setting. Here we have the trainer practicing or demonstrating the procedure on a standalone model, the midwife practicing on the wearable model, and which is being worn by the patient, and the observing student taking notes. On this slide, we have videos of the proper insertion and removal techniques for a device. For insertion, it goes as follows. Insert the trocar at a 30-degree angle, push it in parallel to the skin as you tent it, then put the implant in at one end and push it through with a plunger. As you remove the trocar from the skin, push the plunger in to make sure the implant stays in place. For removal, palpate the skin to find the location of the implant, make a small incision at one end and push the implant through the other, cut away at the scar tissue and pull the implant out with forceps. We performed a number of tests to prove our model was more biofidelic than others on the market. The first was the force required to remove an implant. We were told that students often felt unprepared in removal because removing an implant in real life was much harder than removing them on the models. And thus, we sought out to create an arm that made it harder to remove the implant. Through the use of the fat capsules shown earlier, it requires more force to remove an implant from our arm than any of the other arms on the market from our tests. We were told by clinicians and nurses from the hospital, such as Nurse Amy Lee, that this method feels much more realistic. We also tested pierce forcing. Although removal required more force, pierce force on the current models was satisfactory enough to represent a real piercing on an arm, and so we made sure that our arm was within the bounds of the other models currently on the market. All right. Although pierce force wasn't an issue, we were told that the current models often hinder the proper insertion technique. For example, on the Euler-Zimmer model on the top, the arm is so small that it is often impossible to insert the trocar parallel to the arm, forcing the midwife to drive it into the muscle, which is incorrect. In the Rita model, although it is longer, it has a fat layer made of styrofoam, which is inflexible, so driving the trocar through that layer makes it really difficult to tent the skin and move around. We fixed both those problems in our Citt kit, however. It is both long enough that the trocar can be inserted parallel and flexible enough that if the trocar slightly pierces the fat, it can come out as it tents the skin, a correct representation of the insertion technique. To make sure that our model didn't change in the harsh temperatures that we expected it to be used in, we put several layers of the silicone and the fat pods in an oven at 80 degrees Celsius for 12 hours. On removal, although the silicone was slightly warm to the touch, there were no noticeable changes in how it felt or behaved. We also wanted to make sure that our device was as cleanable as the silicone is tacky and would pick up dirt. And as you can see with the quick rinse of water and soap, it comes out looking good as new. One path we're considering is using the Citt kit to train in other procedures. This idea was brought up to us by Adam Dotson, who told us our biofidelic arm serves as a good platform for training for other medical procedures, such as suturing. Looking forward, we plan to complete human factors testing and force displacement testing before June. As of yesterday, we have filed our provisional patent. In August, we will be performing field immersion testing and getting end user feedback from that, which we will use to iterate our design come September through December, and hopefully obtain a manufacturer in that time period. In the long term, this product could be taken to market quickly because it does not require FDA approval. We'd like to thank the following people listed on this slide, and we will take any questions at this time. Thank you.